And I think we're going to move now into our very first panel presentation. I am very happy to introduce our first panel presentation on the topic of avoidant and restrictive food intake disorder and autism spectrum. Our speaker, Michael Vetter, is a fellow of American Psychotherapy Association and director of psychological services for Nourish for Life and medical stabilization programs at UCLA Santa Monica Hospital. Following his presentation, Dr. Denise Nunes will serve as moderator. She's a preventative medicine and public health professor, physician at UCLA, and Dina Gassner is an adjunct professor at Towson University and member of ARFID's Autistic Researcher Review Board, who will serve as a respondent to the presentation. And then the floor will be open for Q&A. Your questions are certainly welcomed in either the Q&A box or the chat box, and I welcome our panel.
Hello there. Hopefully I can be heard at this point in time and seen. My name is Dr. Michael Vetter. To describe myself, I am a Caucasian male with dark hair. I used to have more of it, wearing glasses, a dark blazer with a light blue shirt. And it is an honor and a pleasure to be here today. Thank you very much. I appreciate the opportunity to speak today because it's an opportunity more specifically for me to learn probably more than I can teach or advise. But I find the topic of both ARFID as well as autism to be one that presents consistently in clinical practice in which I work, and welcome the discussion that follows this presentation. So thank you very much. I also wish to apologize for any background noise that may be disruptive throughout my presentation, as I can't control background noises, unfortunately. Next slide, please. So today, just as a brief agenda, I wish to review briefly the diagnosis of ARFID, just for context, speak a little bit about the parallels between autism and ARFID, try to highlight some of the clinical options that exist on the horizon, as well as what is put into practice now, as well as share some anecdotal pitfalls and voids that I've experienced in care for those who experience both not only co-occurring ARFID and autism, but either autism and or ARFID. And then, of course, welcome and invite discussion. Next slide, please. So the way I want to really sort of set the context and expectations for today is that I know a lot about a little about a lot, and nothing about most. And that really sort of captures the way I feel about my experience, not only with autism, but more specifically ARFID. I entered the world of eating disorders formally and most specifically about 3 years ago. And I've come with a longer history of clinical practice extending past, I would say, 23, 24, maybe 25 years now, but tended to be broader based, focusing more on anxiety and more specifically adult populations up until about 3 years ago, in which I got more situated in adolescent and pediatrics. My experience that has led me to where I am now in my clinical work, I think was a wonderful primer for what I'm continuing to learn. So I really do approach today as sort of sharing what I've learned thus far, and also inviting what I learn or what I can learn in the future. Next slide, please. So to give you some context of the programs in which I work, Nourish for Life and the medical stabilization programs are based in UCLA, in the Santa Monica Medical Hospital specifically. It's oversight and run by Dr. Elaine Rosen, who is the medical director of both programs. I'm the psychological director of both programs, but I'm also the only psychologist in both programs. So far, I'm my own boss and my own worst enemy in that regard. The Nourish for Life is an outpatient clinic consisting of 2 dietitians, 2 pediatricians, and 1 psychologist, yours truly, soon to be 2 psychologists. We are hoping to bring somebody new on next month, hopefully. The population range for those who seek our services is anywhere from about, I would say the youngest is about 7 years of age, all the way up through 26 years of age. The primary issues that come to our clinic and presentation diagnostically tend to be anorexia nervosa or ARFID. We do see individuals who present with binge eating disorder as well as bulimia nervosa. Those tend to be more in the minority, however. Treatment modalities employed in the clinic tend to be centered around family-based treatment, FBT, or CBT with an adolescent focus. The medical stabilization program, again, based at the UCLA Santa Monica Hospital on the pediatric floor, consists of a team of an adolescent medicine physicians, adolescent medicine psychologist, again, yours truly, and then a dedicated social worker and dietitian. Next slide, please. So from the diagnostic perspective from the DSM-5, ARFID, which stands for Avoidant Restrictive Food Intake Disorder, is characterized as an eating or feeding disturbance that's manifested by a persistent failure to meet appropriate nutritional and/or energy needs associated with usually one or more of the following. And that includes significant weight loss or the failure to achieve expected weight gain during the appropriate growth and development of children, significant nutritional deficiency, or the dependence on enteral feeding or nutritional supplements, as well as a marked interference with psychosocial functioning. More often than not, we will see, I would say, 2 out or 3 out of these categories, but it's rare that we see all 4 categories. Next slide, please. The disturbance is not better explained by a lack of available food, such as food insecurities, or by an associated culturally sanctioned practice. The eating disturbance does not occur exclusively during the course of an anorexia nervosa or bulimia nervosa, okay? And there is no evidence of a disturbance in the way in which one's body weight or shape is experienced. And I think that is a hallmark distinction with ARFID, which is there is an absence of concern of weight gain or body shape, body mass. The eating disturbance is also not attributed to any concurrent medical condition or better explained by another mental health disorder. When the eating disturbance occurs in the context of another disorder, the severity of the eating disturbance exceeds that routinely associated with the condition or disorder and warrants additional clinical attention. Okay? One thing that I want to highlight about ARFID is that it's a relatively new diagnosis as well. It was added to the DSM in 2013. So when we think about diagnostic age, really quite infantile in its years on this in practice. So that will come into play later on in my presentation as I wish to discuss some of those anecdotal pitfalls and conceptualizations that we start to talk about. Next slide, please. So quite simply, ARFID intake, in ARFID, intake is restricted for 3 reasons. If you can click forward, please, with the first reason. 1, avoidance based on sensory aspects of food or eating, such as taste, smell, texture. I would include vision in that as well. As we may very well be familiar with, we first eat with our eyes, typically. So vision should be included in that. Next point, please. A lack of interest in food or eating. More specifically, if you didn't remind the person or if they weren't informed that they needed to eat, the hunger cues would be absent. They have a disinterest in eating. They have a disinterest in food. They sometimes lack the hunger cues. So it's not about the avoidance of food for avoidance sake. They just lack the interest. And the final point, fear of negative consequences stemming from adverse events, okay, such as choking or vomiting associated with eating. Typically, I would say the 2 most common adverse events that we see in the presentation do include, in fact, choking or vomiting. There is such a fear of the potential for vomiting that some kids will not even eat as a result of that fact that it may promote either nausea or emesis of some type, where emetophobia almost becomes a concurrent diagnostic consideration. Choking is more specific to a particular food that, like for example, if somebody choked on asparagus, they may be avoidant of eating anything asparagus that contains asparagus or similar in nature. So it may even broaden to green foods or foods that are long and resemble that type of characteristic. Next slide, please. So what's the distinction between picky eating and ARFID? Well, typically for let's just call it typical picky eating, tends to be most common in toddlers and preschools. And with ARFID, we usually can see it as starting as early as the first year of life. And we'll make note of parents who have even reported that their child really kind of recoiled from certain baby foods or certain textural elements. They would just spit it out or they wouldn't take it very, very early in life. Picky eating that we see that tends to be more typical comes later in life, usually around toddler or preschool of age. With typical or regular picky eating, we see that it improves with age over time. With ARFID, however, it tends to get worse over time and preferred foods start to drop off. With picky eating, it's associated more with a normal appetite. With ARFID, we can see one or the other. They may have a normal appetite, or as I mentioned, they may have a decreased appetite lacking hunger cues. With picky eating, it typically does not interfere with social, family, or school functioning. With ARFID, we tend to see that it interferes with at least one of those domains. With picky eating, it's, if faced with the food outside of their preferred range, they usually find a way to make do, or they'll find an alternative, or they'll eat some aspects of what they can do. Maybe like, for example, if they are picky about the edge of certain foods being too crisp or too crunchy, they'll cut those away and they'll eat the remainder of the sandwich or the item. However, with ARFID, they would in fact prefer to go hungry rather than eat or venture outside of that comfort zone. With picky eating, the preferred food type is not specific. It just tends to be, again, very broad-based. With ARFID, it becomes so specific that the preferred food may be so selective to avoid other brands that are not specific to the certain brand that that particular child would like. Another thing that we look at is in picky eating, usually there's minimal anxiety associated with it. However, with ARFID, the anticipation of fear foods may provoke strong emotional reactions. I would say that mimic or resemble panic-like episodes. Next slide, please. So in a large study, some of the characteristics that emanated from reviewing over 700 adolescents, that individuals with ARFID were compared to those with anorexia nervosa and bulimia, and the traits of those with ARFID tended to be one, younger, had a longer duration of illness before the presentation, meaning not just illness, but characteristics and aversive avoidant behaviors, were more likely to be male, and had a higher incidence of coexisting anxiety or other medical conditions, but a lower incidence of coexisting depression. Next slide, please. So let's start to talk and introduce some of the parallels that we see between ARFID and autism, okay? In a very broad-based review, back in, I would say, the early aughts, it was estimated that problem feeding behaviors were present in anywhere from 46 to 89% of children with autism. Okay, subsequently, a more specific meta-analysis was undertaken and noted that children with autism were 5 times as likely as children without autism to have feeding difficulties. What is interesting about this is if you look at the dates of those studies, 2006 and 2013, those all sort of predated the diagnostic inclusion of ARFID. So selective eating or problematic or challenging feeding behaviors have long been present and associated with autism, predating the diagnostic classification of ARFID. Selective eating generally referred to frequent food refusal, limited repertoire of foods, so highly selective, excessive intake of a few foods, and selective intake of certain food categories. And in fact, earlier on, feeding challenges were so common an occurrence that it was actually once back in the 70s A diagnostic criteria for the autism spectrum. Okay, that is more recently not as inclusive, but it's just to note in a historical context. It's important to note. Current research shows that autism is seen with those with ARFID at higher rates than the general population of a roughly 1.5%. Estimates of co-occurring ARFID and autism range from anywhere from about 12.5% all the way up to about a third or 33%. Okay, it's significant. And again, I think what we're faced with is the definition and understanding and conceptualization of ARFID. Again, when we start to see a prevalence of feeding challenges in autism that range anywhere from 46 to 89%, it's more likely happening with a greater degree of frequency, but doesn't always necessarily get defined as ARFID or doesn't meet the criteria for ARFID. So just something to consider. Next slide, please. Okay, the sensory difficulties often experienced with individuals with autism and the sensory sensitivities found with many individuals with ARFID have very strong parallels, but one does not always signify the presence of others, okay? Research has demonstrated that children with autism display higher oral oversensitivity than children without autism. Next point, please. Similar experience of oral oversensitivity is also seen in ARFID, where certain types and textures of food may feel disgusting, anxiety-producing, or frightening to eat. And I think this is an important thing to consider because, remember, going back to the distinction in terms of the eating disorder world and criteria, with anorexia, we see that the fear is not associated with food, but the consequence that food brings, more specifically weight gain and body mass. When we look at ARFID more specifically, the fear isn't of the consequence of food, specifically weight gain or body mass, it's the fear of the food, either the sensation or the fear of vomiting or choking on it. So it's a very different pathway than what we would see in anorexia. And in many ways, this mirrors and parallels the same type of oral oversensitivity that we find with children who have autism. Next point, please. Some have hypothesized that ARFID patients with sensory sensitivity are not just overly sensitive to certain foods or tastes, but that their taste perception is more intense. And I find this to be a very interesting hypothesis and presentation. That, for example, mild tasting food could taste very strong to someone with ARFID, not just the novelty of it. And when I think of that, and I encourage you to think about this, is that it is very hard to gauge the perception of someone relative to our own. So that's why it's important, and when I assess somebody who's presenting to our clinic with a potential diagnosis of ARFID and or autism, is I try to get a sense from them is what do they define as mild, moderate, and significant and or severe. For example, something like ketchup, which can be somewhat sweet and at the same time a little bit tangy, while for some children it is a favorite and preferred, for others it may be very overwhelming and powerful. So gauging their experience of that is so critical. Next slide, please. In fact, there was one patient named Juliet who shared with us that for me, the idea of eating a piece of broccoli is equivalent to eating the hair and soap mush that collects in the drain of a shower. And I thought that was such a visceral and wonderful descriptor for what the experience is like. I have to profess, I am not a broccoli fanatic. I don't enjoy broccoli tremendously so, but I can eat it, okay? And I will eat it for its benefits, okay? But the idea for me of tolerating broccoli is one thing. The idea of me of sort of eating and consuming mushy hair that was collected with soap at the bottom of a shower drain is intolerable. I could never do that. So to make that kind of connection, to make that kind of parallel, it's well beyond the fact that I just don't want to try a new food. It's really getting to this notion of the fear of the sensation of something that is so dystonic. I would even go so far as to say toxic in its presentation, is so important to understand and conceptualize from the standpoint of food sensitivity. Next slide, please. That brings us to the issue of rigidity and sameness. And that's another shared connection that I have found between the presentations of ARFID and autism, is that there is a tendency and a pattern of sameness and cognitive rigidity. Individuals, as we know with autism, tend to have narrow interests and make use of repetitive behaviors, which to some degree actually can be beneficial. However, when we start applying that to eating disorders and to more specifically the ARFID presentation, when we become more narrow in focus and repetitive in focus, it really presents as a challenge in terms of the cognitive flexibility and broad opportunities to take in food. Next slide. With regards to food, some individuals with autism may show a preference for sameness, okay? And this looks like, for example, the same brand of chicken nuggets, okay? Or only eating breakfast at a certain time, or eating lunch at a certain time, never earlier or never later, okay? Changing from one food brand to another could be a hugely distressing and overwhelming process. Next point, please. A similar type of capacity to set shift or change from one task to another mental set of concepts has been seen quite extensively in individuals with autism. So, for example, changing from brand 1 chicken nugget to brand 2 chicken nugget, even though they're both made out of breading, even though they're both made out of chicken, okay, is a set shift. And it becomes a challenge. Next point, please. We see that mirrored in ARFID. Okay, when someone with autism could cognitively recognize the new task, okay, it's time to switch brands or it's time to try something new, they may have difficulties in actually switching. And the concept of difficulties or challenges in set shifting and rigidity has been implicated and observed in ARFID. So what exactly does that, actually look like? Well, from a standpoint of trying new foods, okay, we get to this whole point of, even though they may recognize, yes, it's chicken, yes, it's breading. I'm using chicken nuggets as an example because it's a staple. In those things, we start to see that I really will believe that the capacity to recognize the difference may be there, but the ability to shift sets, to change sets, there is something that prevents them from making that leap. And again, it goes back to that desire for sameness and cognitive rigidity. Next point, please. Case in point, okay? These are the foods that we typically see preferred for those with ARFID or diagnosed with ARFID. Whether we call it the white diet because most of these foods take on sort of a white color, whether it's pasta, white bread, chicken nuggets, crackers or pizza. These seem to be within the repertoire of what is preferred from the autism individual, not from the autism individual, but from the individual with ARFID and at times autism. Now, that being said, what is interesting is the reason why I have the photo here of Dino Buddies or Dino Nuggets, okay, Dino shaped nuggets, is you can have a chicken nugget, and this is anecdotal. You can have a chicken nugget that is made by the same manufacturer, the same company, with the same ingredients exactly, yet they are not dino shaped. They are just regular nugget shaped. You can present that to an individual with ARFID and they will not eat it. They cannot do it. And that is not even based on the sensory aspects of taste, texture, or smell, purely on vision, which goes to my earlier point before, which even visually, if it doesn't look the same, and that goes back to the supporting sameness and cognitive rigidity, they will be avoidant of it and fearful of it. Next slide, please. This really presented as a significant challenge during the COVID-19 pandemic, okay? Many households, I'm not going to go too much into this, but many households during the pandemic experienced heightened food insecurity as a result of supermarkets being lacking certain items, being just completely raided, and or just the unavailability to even go out and purchase foods, okay? Nearly 18% of US households with children reported food insecurity during the pandemic, compared to 11% of households prior to the pandemic. But this made it particularly distressing and impactful to families with ARFID and food selectivity, where brand-specific foods were no longer accessible. I was working with an individual who, in addition to only eating waffles, would only consume Costco brand lasagna. And the Costco brand lasagna had to be presented in a way where the cheese was stripped off and the sauce was removed, and would only eat the noodle. But the noodle had to be from the Costco brand lasagna. During the pandemic, this family was unable to get to Costco. And when they finally were able to get to Costco, they were sold out of the lasagna. It caused significant stress and malnourishment during that period of time for this family, because the child would only eat that or waffles. So they had to shift to only providing waffles as a source of nourishment for a particular period of time. Next slide, please. So when we start getting into treatment considerations, feeding problems are complex and often multifactorial. Okay, complex problems are often best addressed using an interdisciplinary approach. I think everybody who's participating in this conference today would likely agree with that. What I find interesting is, more often than not, those families who present to our clinic are there because of the, I'm going to call it the simple, but it's far from simple, but the simple reason and fact that their child is not eating. It is eating. It is through the act of nourishment and eating that they cannot attend to that basic need as a parent to their child. And that is what brought them in. There may be other coexisting variables, factors, presentations, anxiety, depression, sameness, OCD type behaviors. All of those things may be co-occurring, but it didn't warrant for the particular family any type of intervention at any particular point of time. But the inability to properly nourish their child is what gets them through the door. And that is why in our clinic, we often will see the presentation as it relates to an eating disorder or disordered eating, but it could open up to a much wider exploration of other co-occurring features that warrant further investigation and assessment. Next slide, please. That's why assessment is so critical. Very often with patients who present to our clinic and families that present to our clinic, we are the first stop. Not all, but for many, okay, especially when it comes to ARFID. It's not unusual that I will make the recommendation for either a developmental or neuropsychological assessment. More often than not, what I am looking for is there co-occurring autism or high-functioning autism present that hasn't been brought to the family's attention as of yet, okay? Given what we know of the heterogeneity of autism and the diagnostic complexity associated with it, neuropsychological testing of individuals suspected or confirmed to have autism really does require clinical expertise to design personalized testing batteries, interpret the results with care, sensitivity, and expertise, while accounting for autism traits, behaviors, and common other potential psychiatric presentations that may be co-occurring. So right from the get-go, I'm thinking that not everybody gets referred, not everybody gets recommended when they present with autism, with ARFID, but I want to be mindful of the possible presentation of autism, because again, it lends itself to a much more robust, I would say, team of care, making sure that we're not just solely focused on just the food selectivity and eating restrictions that come with ARFID, but if there is a more global presentation where support can be offered, intervention can be offered, and mechanisms of either behavioral intervention or therapy can be offered, I don't want to miss out on those opportunities. Next slide, please. Okay. So again, I go back to the, if you will, the last premise when we get to the DSM-5 diagnosis criteria for ARFID. When food avoidance or restriction is primary and associated with significant medical, nutritional, and/or psychosocial compromise, it generally requires clinical attention outside of what would be warranted in treating just the co-occurring conditions alone. We have to be mindful of everything. We have to develop the full picture. And unfortunately, treatment thus far in terms of clinic presentations and resources hasn't been able to provide that in a comprehensive way yet. And I'll get to that in a moment. Next slide, please. Okay, so what are the first steps when I meet with somebody with a consideration of ARFID? Number one, okay, please go to the next point. Determine the degree of medical intervention. In other words, is malnourishment so severe that hospitalization is actually required in order to medically stabilize? This is critical. If heart rate is compromised, if their metabolic state is in any way compromised, before we even get into the outpatient management of this particular family and patient, we need to medically stabilize. So that's the first question. Next point, please. Is weight appropriate, thereby allowing the focus to be on selectivity? The individual may not require hospitalization, but is their weight low enough, or are they appropriate where you can begin increasing cognitive flexibility and broadening selectivity? If not, the focus needs to be on weight restoration and making sure they are at an age-appropriate weight. Next point, please. Also, we want to assess for the severity of co-occurring features. And what do I mean by that is, food selectivity may be the primary reason why they're there, but what is the degree of anxiety? Is the anxiety generalized beyond food selectivity? If something such as anxiety is so intense that even just the conceptual idea of eating is prohibitive, then we may want to address managing and addressing the degree and intensity of the anxiety first before we even get into addressing the issue of food selectivity. Next comes the issue of attending to parent anxiety, expectations, and education. The first point, please. Most parents, when they come in and they meet me for the first time, they want the problem resolved, okay? My child doesn't eat enough, and if they eat enough, that they are only eating 3 or 4 things, we have to fix this, fix it. And so it's, it falls upon us as a treatment team to be able to educate the parents that this is not a simple issue of just, your child being oppositional or being stubborn, but this carries with it much more complexity and finesse. Next point, please. That parents are often frightened or worried. For the sake of time, I'm going to go to the next point, please. That parents are often frustrated and they feel neglected by their healthcare providers. And what do I mean by that is, it doesn't mean they're brushed off, but they are often used to hearing with food selectivity, don't worry, they'll outgrow it. Pickiness is normal, they'll outgrow it. By the time they come to us, they're well past the point of saying, look, there's something going on here. They're not outgrowing it. Help us, okay? And they feel neglected. Next, please. I also look to assess the family dynamic and the parental investment capacity. In other words, what are parents in a position to do? Because more often than not, this is going to play out in the home. This isn't something that is resolved in clinic. This is something that is introduced in clinic and practiced in the home. So I really want to get a strong sense of the family dynamic. Next slide, please. So there are a few newer modalities that are being introduced specific to the treatment of ARFID, as well as co-occurring ARFID and autism. One is called SPACE ARFID, okay, which was out of Yale University. SPACE, standing for Supportive Parenting of Anxious Childhood Emotions, is a novel outpatient parent-based treatment that focuses on the parallel responses to child problematic eating behaviors and aims to promote food-related flexibility. The Buffet program, which is out of the Children's Hospital in Philadelphia, stands for Building Up Food Flexibility and Exposure Treatment. You gotta love these acronyms. Provides an outpatient treatment option for older youth with autism and selective eating who have thus far been underserved. It leverages CBT strategy to help children develop skills to cope with the anxiety, to think and act with greater flexibility with new or non-preferred foods. And then finally, we have family-based treatment, or FBT, for ARFID, okay, which maintains an agnostic approach. In other words, we don't really look at or are concerned by why they have ARFID. They promote an externalization or separation from the illness between the patient and the family. So in other words, don't blame your child. Look at it from a standpoint of it's ARFID. So if you want to focus on anything, separate ARFID from your child. Emphasizing the serious health and developmental problems that ARFID brings about if it's not already addressed, and empowering the parents as the primary agents for managing behavioral change. I think in some ways, we've tried using FBT for ARFID. I think I would just say anecdotally, mixed results and success with that. Next slide, please. So with spaced ARFID, what you see here is you have ARFID-related distress. You have family accommodation, meaning they'll give them only what the individual is willing to eat. You get short-term reduction of distress, but then you have a continued dependence on the parents for regulation, and you maintain the symptoms of selectivity, and round goes the cycle. Space ARFID is designed in its theory and its essence to promote flexibility and give parents the tools to effectively support and move through those distressing moments so that they move away from accommodation and they move more into cognitive flexibility. Next slide, please. The FAY model, again, the child treatment modalities in this case focus on anxiety, flexibility, and the sensory and taste aspects of their presentation. The parent training comes into psychoeducation and support with the goal of increasing food flexibility and increasing a larger food repertoire. Next slide, please. So what are some of the barriers to date of effective care? One, there's inconsistent degrees of expertise and comfort in the assessment and detection of autism and or ARFID. Next point, please. There's a lack of affordable and available neuropsychological and developmental assessments. Just to give some idea, right now in the private sector, it can be anywhere from, I've heard, $6,000 to $10,000 for a neuropsychological evaluation. In the public sector, you may find more affordable alternatives, but it could be anywhere from a 6 to 10 month wait list as a result of demand, stemming in part from the pandemic. Next point, please. There's a positive community resources that can attend to the selective eating components of autism while also addressing other behaviors. In other words, there's silos of care. And what do I mean by this? There have been parents that I have referred for resources and if you will, treatment centers of care for autism. But when they present, the treatment center itself will say, well, we really don't have the resource, or we don't really feel comfortable treating the eating disorder, the ARFID. So we're not appropriate for you. And then they come back to us and we're like, well, we don't have the resources to support you in the manifestation of the autism. So here we have, parents are left with very little, and we have these defined silos of care. Next point, please. The newer diagnosis of ARFID is still finding its diagnostic footing. A lot of people don't even understand what ARFID is. In fact, it wasn't too long ago, I was collaborating with another psychiatrist and another psychologist, and they kept referring to it as ARFID. It just goes to show people are aware of feeding difficulties, but now ARFID is at risk of becoming sort of a wastebasket diagnosis, where it's like, well, we don't know really what it is, so it must be ARFID. It's kind of very similar to that notion of, EDNOS. Final point, please. Okay, so the concluding, that's okay. The growing need for multidisciplinary centers of care that offer one-stop shopping for families. So basically, a place that people can go where food selectivity as a part of autism, as a component of autism, isn't necessarily factored out and said, well, this is an eating disorder, we don't see it. And by virtue, where we have eating disorder clinics that can more appropriately support if the feeding selectivity and challenge is the primary issue in getting in the way, having supports in place that can also address the other co-occurring features that may be associated with autism. Okay, last slide. So ultimately, it's highly likely that the key to addressing ARFID with co-occurring autism is the recognition that one may affect the other, and to find fulfilling recovery goals that fit with the person, their ability to access support, and their diagnoses or potential diagnoses. Not just looking at it so circumscribed as it's either this or that, but really looking at the person. What is the challenge? What is the struggle? What is the difficulty? And how do we address that and overcome that and support it for the family? Next slide, please. All right, you can go to the next slide. If you have eagle eyes, you can see that. Thank you very much. I apologize for going slightly over. There's a lot to address, but I look forward to the discussion.
Thank you very much for sharing such fascinating information. We do have a couple minutes left that we can use for some Q&A, and here is where we will welcome Dina Gassner and Denise Nunes.
I don't want to take away someone's question, so maybe we want to have some of those questions addressed. There are a couple in the chat that I thought align with what I was going to want to discuss anyway. So maybe we want to go there first. What do you think, Denise?
Sure, I think that would be a great approach. Hello, everyone. Denise Nunes, Latinx female with brown hair and a black suit and glasses. Glad to bring up a few of the questions from our attendees. Thank you for sharing. And thank you so much to Dr. Wetter for his great presentation. So the first question from our attendees is, do you see pica behavior with ARFID?
A great question. And I will say this, I'm only going to speak from my experience and what I've read, which is no. I look at the two as typically a little bit more mutually exclusive. And I don't see a frequent co-occurrence of that. I actually, clinically, I haven't seen any co-occurrence of that myself. That doesn't mean it doesn't exist, but it's certainly not frequent.
Thank you so much, Dr. Wetter, for sharing your experience with us. Another question in the chat is, how do you communicate or document with autistic folks who seek justification or support for their ARFID behaviors? And this is an autistic adult who doesn't have ARFID, but has friends and colleagues who have ARFID and spend a lot of time defending their behaviors, writing to companies to not change their formulas. It sparked spicy debate, as mentioned by the person with the question. So wondering how this trend has showed up in your research and how you work with it.
You know, it's a fantastic question, and I think it's a critical question. And it's one that I'm not going to claim to have a perfect answer to, because quite simply, I just don't know yet. I think there are significant aspects to that are really quite important. The way that I approach things, not only just in my documentation, but in my relaying of this to families and individuals, is that, again, I look at this as an aspect of their sensory interaction with the world, okay? Just like with someone who has, for example, hyperacusia, who's extremely sensitive to sounds chewing or whatever it may be. It's not that, hey, you have to just learn how to adapt. It's how do we find a way, you know, to either modulate, help with, or broaden to a certain degree and understand what is the selectivity based on? How do we modulate and possibly regulate that degree of sensitivity so that perhaps you have a bit more wider range of tolerance, okay? But I think this is where a common mistake comes into play, which is like, well, you don't think it tastes good, you'll get over it, okay? Or you think that it just doesn't feel good, that's fine, just have more of it and you'll get used to it. And that's why in many ways I brought up, even though it's disgusting, the shower drain, you know, photo and picture, which is, it doesn't matter how many times you feed me hair that's stuck in a shower drain, I'm not gonna like it, I'm not gonna tolerate it. It's gonna be, in fact, more, you know, intolerable and anxiety provoking every time I come to the table. So I think that this becomes a broader communication, again, with the food industry, okay, in terms of, you know, every time that, you know, like say new and improved flavor, new and improved formula, okay? Well, you know, is there a way to have a new and improved flavor or formula, but still maintain the original? I think there needs to be, you know, a movement, if you will, at least a conversation with food companies and providers that could have radical implications for someone who is so dependent on that particular type.
Thank you so much. There are more questions, but we'll probably be able to email you all. Appreciate your presentation, and thank you to everyone for your time and attention, and enjoy the rest of our session.
Thank you very much. It's been an honor.
My name is, what happened, guys?
What do you need, Dina?
I thought I was going to give a closing comment. I guess we're done.
No, you're absolutely welcome to. Please do.
I know, but Dr. Wetter left. Anyway, my name is Dina Gassner, and I am a gradually white-haired autistic individual. I'm a PhD candidate and a researcher, and I feel like Dr. Wetter was in my house. because we are a house of multi-generations of ARFID issues in our family. Some have been able to be resolved through natural developmental progression, but my son went through what I would describe as food hoarding during COVID, the first time one of his preferred foods was unavailable to him. Fortunately, his mom's a social worker, so now I know how to make a lot of phone calls until I get the case of macaroni and cheese in the blue box of a certain shape. We also took a very neurodiversity-oriented approach to this. We were fortunate enough when I was having the mom panic to have a nutritionist who advised us to remember, first of all, that a French fry is a vegetable, and that the food pyramid could be approached from a weekly goal rather than a daily goal. And so I thought that was really very soothing to me as a parent. Also early on, I had another speech language pathologist describe organized food versus disorganized food. Organized food is peanut butter. When you put it in your mouth, it stays where you put it. When you eat certain foods like a cherry tomato, it is a sensory assault because it kind of explodes or disintegrates into multiple pieces. And all of that fosters such a great empathy on my part as a parent. I would agree with Mr. Katz's question around autism in adulthood and the fact that it's interesting that ARFID shows up with the same diagnostic barriers as autism, right? That autism in women is diagnosed later, that we're early diagnosis lacking for females, and it appears this could be comparable. Maybe females are sliding into the ED category when their needs could be best addressed through the lens of ARFID and autism. I would also add to the list of things that contributed to our scenario, which I don't think is rare, and I think it's a great area for future study, is examining the sense of taste and the sense of smell and whether that's implicated. To our shock, because a sibling tried Harry Potter beanie bots that taste like nasty things, I think we discovered our son doesn't have a sense of taste or smell, which would certainly amplify texture as the system in his sensory toolkit that ascertains whether things are safe or not. I would also say that we sought to ensure that he had one food he could eat at any type of restaurant so that his socialization was not impaired by accessing foods in different cultural settings, for example. And I think for my son, extraordinary episodic dental trauma has significantly impacted his ARFID. It actually increased it when he lost a crown. So now he's afraid to eat any noisy food. So now we're hearing another input that auditory is a factor. So I think that this is really timely. I think it's a very important topic. I do hope that we can do more going forward in looking at adult manifestations. And I saw a meme today that was so interesting on Facebook. It said, "I can't taste my food when people are talking, Mom." How genius is that? That whole idea of one system being able to work at a time. I think that's so critical for us to be aware of. So I'm hoping that we can get more autistic researchers, more families with lived experience plugged in to inform the research, and that we can expand the research to look at what only autistic adults can report to us. But I think that, soothing anxious moms, having been that mom, I don't usually bring that hat to this forum, is a critical piece of that. So thank you, everybody. And I appreciate being the discussant for this session.
Great, thank you so much, Dina. Appreciate all your contributions and everyone's questions. And we hope you enjoy the rest of the research day.
Thank you so much. That was a wonderful presentation and discussion. Dina, your family stories just have so much to teach us and so much to teach how the research is done and what we are looking at. Thank you so much for sharing that. We are going to move forward into